This next video is going to cover evaluations. Now, every facility is going to have different components that are included in their evaluation. And so some may have more, some may have less. And depending on the continuum of care and what type of services you are providing, your evaluations may look differently. Some settings, they may be more robust in certain areas because you've really are working on fine-tuning of skills, and the deficits are more narrow and focused versus in acute care. For some patients, they have deficits in a multitude of areas, and so you're capturing that across the board. And so it just really depends on the patient and the setting. But this is just going to go step by step, and it's going to follow the order and the structure and the format of the various settings in which I have experience in. And then you can pick and choose what information may be helpful to carry into your practice. So the first thing is to understand why your patient is seeking services. So like, what are they currently being hospitalized for? And this is something that I didn't think would be as overwhelming as a task as a new clinician. They call it practicing medicine for a reason. Not always will our clients have clear cookie cutter diagnoses. And so for somebody's current hospitalization or why they're in the hospital, you may have a nice clear-cut diagnosis, or in some instances, you may have a list of symptoms, or you may have a list of etiologies that they are trying to rule out, or they may say it's possibly this, or it may possibly be that, and so you just are going to capture that information. The other thing is it's very important to document any surgeries that your patient has had, including capturing if you know if there's any pending surgeries. So maybe your evaluation came in and they've already had a surgery and they need to have a second one, or maybe your evaluation is happening so you can do a pre and post to compare how surgery impacts somebody. But it's really important if they haven't had surgery that pending surgery is also captured in your documentation, for the chance that maybe when you come in and do that pre-surgery evaluation, maybe they're functioning independent or modified independent, and it's not really justifiable to pick them up for services. So if you know that they have a pending surgery, and they which might warrant a reevaluation or reassessment after that surgery, so the patient doesn't fall through the cracks, it's important to like capture all of that information in your evaluation, including the fact that I'm just going to add this little caveat here that don't ever underestimate the power of anesthesia. I don't know how many patients I had seen prior to surgery and then I would see them after, and like their cognition can go on a little bit of an adventure, an excursion. And some patients, it takes them a few days to a week sometimes to recover from anesthesia, and so they may need some work after surgery that has nothing to do with any like precautions or physical limitations. It may be cognition, so just something to keep into mind. Imaging is a really important thing to also include in your documentation. It's really helpful for clinicians that follow behind you to understand like where a fracture might be located. It really helps when you're making decisions on how to do safe patient handling, how to educate a patient to move, if the fracture is mid-shaft versus proximal or distal. Like really can impact what you can do to make your patient comfortable during moving. And so that's why that information is helpful, including also those neuroscans. Understanding the location of an infarct or a traumatic brain injury can also shed some helpful information in your evaluation. Precautions. Precautions are something that we get in a routine of like capturing the big ones like fall and aspiration, and weight-bearing precautions, but sometimes those can be easily missed, and that section can be taken for granted. But it's one of those things that we need to capture for the safety of our patients and for anybody that follows behind us. And I do understand that from the evaluation, things can change and precautions can be added, but whatever was present at the time of evaluation should be included. So, past medical history. This is something that comes with time and experience, especially in the acute care setting. You can have patients that have a very long list of medical history, and in our documentation, depending on what facility or their history with our facility, some of the stuff is auto-populated and some of it is like no history is available. So you have to learn as a clinician and decipher like what is the most prevalent and relevant information to include for this specific hospital stay. Like what past medical history is going to impact their plan of care, and that would be beneficial for everyone that works with the patient to know. And so that, I think, just comes with time and experience. Prior level of function. This seems pretty straightforward of like just being able to capture how the patient was performing with their baseline activities prior to this admission. And I think we practice that really well in school and we understand that part. I think the part that we don't think about is when our patient, for whatever reason, is unable to provide that information, whether it be that they're on a ventilator, a medically induced coma, they're aphasic, or their cognition has been impacted and they're not a reliable historian. We need to maintain the integrity of our documentation and capture in that moment that based on these variables, this patient isn't a reliable historian at this point in time, unable to obtain prior level of function. Because you may think it's safe to assume that somebody was independent prior, but that may not have been the case. And so you want to maintain the integrity of your documentation and just be honest and include that information. And sometimes you have family or a reliable caregiver or a POA that is able to provide that information at the time of evaluation, but sometimes those sources are not available or they haven't been verified. And so you just include what you can while maintaining the integrity of your documentation. Cognition. So at my facility, cognition included, basic orientation, problem solving, safety awareness, processing, sequencing, ability to follow commands, but also included vision, hearing, and speech. Also were included under cognition. Now, typically, when I reviewed documentation during my residency, I didn't really see too many issues when it came to the basic orientation and sequencing and problem solving and capturing those components and verifying if somebody had an issue. Where it becomes a problem and you have to really think about new skills that a patient may need to go home with maintaining a new precaution, such as a weight-bearing status or spinal precautions. Sometimes, like, you can have a conversation with them and their cognitive faculties are really intact, but we don't think about how they may be with learning new skills and following new instructions. So I would oftentimes see inconsistent and incongruent documentation. I would see that cognition was listed within functional limits, and then in a plan of care and under the problem list, like safety awareness was included, but under cognition, safety awareness was evaluated and it was marked within functional limits. So you can't have something within functional limits be a problem, and then include it as a parameter and a goal. And I think this happened because in your regular assessments and screenings, they passed and they did just fine. But they want to include safety awareness as part of their goal parameter because a person's going home with a new precaution and they want to make sure that they can maintain it and adhere to it. And so it's just being accurate and capturing that in your documentation and throughout the entire process. So under cognition, make sure you're either screening how they learn new information and how they're able to adhere and apply it, or maybe, put that, all of these other things are within functional limits, but due to this new functional limitation and having to adhere to these precautions, safety awareness may be at a supervision level, and that's okay because that gives you the ability to give verbal cues and all of those things. So that's just something to think about when you're assessing cognition and just maintaining the integrity of your documentation. Upper extremity assessments, which this is going to include manual muscle testing, range of motion, edema, sensation, coordination. This, once again, is another pretty straightforward section to capture what you did, how the patient performed. But this is an area where you also need to be really careful when it comes to precautions. Sometimes after a patient had a CABG, I would see upper extremity range of motion just listed as within functional limits, but no parameters had been included in the documentation. The risk of doing that is that somebody else that comes along may interpret that very differently and may think that you had your patient not adhering to certain precautions, that you let them do like full shoulder range of motion. So it's really important when there's a precaution involved and a joint or another body part needs to be protected, that you include that in your assessment. So you would say, range of motion within functional limits within sternal precautions, so that they would know that you stopped at 90 degrees shoulder flexion. And it doesn't take all that much more time, but it just protects the integrity of your documentation and captures what actually happened and doesn't set you up for any sort of litigious processes that might come to fruition as a result. Same thing with manual muscle testing. This is an area of debate. Some people think that you can do manual muscle testing after a CABG, and some people don't recommend it. So at this juncture, if you were going to do manual muscle testing or if you were not, a safe way and accurate way to document this is formal manual muscle testing was not completed due to sternal precautions, based on observation during range of motion assessment, patient able to achieve shoulder flexion 90 degrees, able to maintain against gravity 3+ out of 5. That's the safe thing. You don't know what they're going to do with resistance, but you do know that they can hold against gravity, so that's a safe way to capture that information. And so it's all about protecting the integrity and the accuracy of your documentation and just being really smart on making sure you're including precautions into your evaluation, into the language that you use. Lower extremity function. At our facility, there is a lower extremity assessment section with the same thing with range of motion, strength, edema, sensation as the upper extremity portion. There are also mixed reviews about this section of our documentation at the facility I was at. Some OTs filled it out, some did not. And that kind of came down to some people just are like, we're OTs, we don't have anything to do with the lower extremity. And then you have other people that are like, wait a minute. if I'm getting patients up and moving them, like, then I should include that in my evaluation, because it might be the exact reason why they're not safe to go home and perform ADLs, because you have to use your ADLs, or have to use your legs to do ADLs. And so it is okay, in my opinion, that we include and capture that information if there's a range of motion deficit, a strength deficit, or they have a weight-bearing precaution that would change how they would be performing ADLs. Then it's within our scope of practice, and that it is a responsible thing to do, to include that information, and there's nothing wrong with us doing that. And so whether you have that section or you don't, I think that is justifiable for an OT to fill out that section. It just adds to the robustness of your documentation. Activity tolerance. These next few sections really start to semantics start to become really important in how you are capturing the clinical picture of how your patient performs. With activity tolerance, you just want to paint the picture of how the patient's performing the task and what that does to their endurance level. And the thing I just want to caution you of is, I see so many people that are like, oh, their endurance is fine, and I'm like, yeah, it was fine for a few minutes, but did we like really push them to the extremes? And think about, these patients are just sitting here laying in bed, and in the hospital, their food's being brought to them, their bathroom might be much closer to them than what it would be at home. Someone's taking care of gathering all of their medication and bringing it to them. They have this whole arsenal of support helping them perform their everyday task. And at home, they're going to have to go home after laying in bed in the hospital and becoming weak each day. They're going to have to do more for themselves. And so we really need to make sure when we're assessing and evaluating activity tolerance that we're being accurate and the clinical picture that we're painting is accurate. Because I see a lot of discrepancies here and a lot of variations in this area. So that's just something to think about. Balance. Balance. Ours is broken up into static sitting, dynamic sitting, static standing, dynamic standing. This is also a pretty easy one to capture and to document. For whatever reason, this is the area that I saw the most inconsistencies with marking it within functional limit and then it showing up in a plan of care. Our goals and our goal space is precious, and time is even more precious nowadays with the way reimbursement works. And so if a patient is like functional or like borderline being functional, and then they have some major deficits in some other areas, like our priority should be on safety, teaching them new precautions, and for working on their biggest deficits to make them safe to go to their next level of care. And so I would see consistently like all 4 sections be marked good or good minus, which basically means that your patient's functional. In the areas of balance, and then under the plan of care as a goal parameter, I would see supported sitting, and I'm like, wait, why would somebody that has good or good minus balance have a parameter of supported sitting? And I think this is what happens, is we want our patients to be safe. And so sometimes we want them to do tasks in supported sitting because it keeps them safe, or we know they have an activity tolerance deficit, and so we want them to be safe as an energy we want them to do supported sitting as an energy conservation technique. Well, you have to then you need to choose the right parameter to include in your goal. yes, we want them to do it in supported sitting. We want them to be in a chair or something to help with either a cognition issue where safety or impulsivity is a problem, or as an energy conservation technique, and that's why we may be choosing supported sitting. But when supported sitting is chosen as a parameter, that might be perceived as that you're working on balance, and that really isn't the case, especially if balance is within functional limits. So just be really careful. Even though you want the task to be performed in that manner, the goal should include the parameter that you're specifically working on. So if it's safety awareness, and we need them to sit in a chair because of impulsivity, then put safety awareness. If they have an endurance problem and we're incorporating energy conservation techniques, that's the parameter, not balance. And so that's just something to be really mindful of. And this just shows you like how the critical thinking and the critical rationale and like really understanding like what your documentation is saying means. And it just comes with time and experience. So I just want you to think about those things. Functional mobility. This is a section where your entire assessment so far really starts to come together. So not only what you perform, like what the patient performed, how much assistance they need, what type of devices are included in this, but you really need to start to wrap everything up into a nice little package. So this is where you can start to say, like, based on a weight-bearing precaution, which is impacting balance, or cognition is impacting patient sequencing, all of those different components you just assessed can be included into your functional mobility section. Like, functional mobility and the safety of this task is impacted by balance deficits, activity tolerance, cognition. You can really start to paint the entire clinical picture in this section. Now, saw some really interesting things in my assessment, which I know we all learned something very different, but I just want to forewarn you that it could be out there in the places that you are going off to practice. A lot of places follow FIMS and have structure and rigor associated with that, but then some have places where people have created their own little way of communicating assistance levels. I saw a plethora of notes that had like min assist ×2, and I'm like, what? How is this possible? Even if you're each doing 20, does that mean each of you are doing like 12%? Just remember that assistance levels are what the patient is doing and contributing, not what you're contributing. So there might be two of you there, and no, you may not be doing 75% of the work because another person's present. You don't judge someone's assistance level based on the effort that you're putting in. It's based on the effort that the patient is able to contribute. Because I think that trips people up, and it's how you get weird things like min assist ×2. And so just take that in mind. And if you are at a place that's pretty rigorous with FIM scores, anytime it takes two people to perform a task, it's always total. Just to let you know. Activities of daily living. Just like the functional mobility section, this is the time where you start to put everything together, all of those other things you assessed and evaluated and how they're impacting a person's ability to perform the task. And it's also very important at this point to capture if anything was graded, if these tasks, so meaning like the parameters in which they were performed. So if they were performed at the edge of the bed, or if you did them actually standing sink side, unsupported sitting, supported sitting, because if you did something in a seated position that's normally done in standing, the patient actually might have performed better in a seated position than they would have standing. And so it's really just important to include that in your documentation and to capture the accurate clinical picture that happened at that very moment in time. Okay, the next part is then you're going to start working on your plan of care, and the duration um, of services and how long a patient's going to receive services, I found is kind of every facility has their own set of parameters and rules that they follow. And that's just to make sure that no patient falls through the crack and that everyone gets reevaluations and reassessments that align with insurance parameters. And so you'll learn that at your facility, and it's not too difficult to navigate. OT assessment section. I found this surprising at a couple of different places I've been at. This isn't always utilized as much as it should be. This is the whole reason why we're the registered occupational therapist and that we work so hard for this degree. This is the point where we get to use our clinical voice to justify based on the reason why our patient is seeking services, and these deficits and these barriers to their ADL performance is preventing them from being at their prior level of independence. And it's the justification for why they need skilled occupational therapy services. And so this is a point where you're going to package your entire evaluation together and justify why they need your services. Or on the flip side, also set the case for and justify why they don't need skilled services at this point in time. And speaking of at this point in time, I would say that throughout your documentation, if you are working with a patient and there is an area that doesn't have a deficit, I always put, patient currently does not present with any acute cognitive deficits at this point in time. Patient does not currently present with any bilateral upper extremity range of motion deficits at this point in time. Because maybe you evaluated them earlier in their hospital stay and then they stay at the hospital. And 3 weeks later, you come back in for a reevaluation because this person's had a decline in functional status. It just is supporting evidence that when you saw them the first time, they didn't have any at that point. But in the future, because they were bedridden, they had additional medical complications that came up, maybe then they did present at a later date. And it just protects you and it protects the integrity of your documentation. So something I do, it takes more time to do, so some people don't like to do it. It just kind of depends on your comfort level and your personality. So when it comes to making short-term goals, long-term goals, I think it's important to prioritize. Pick those goals that are the most important to your patient. So making it client-centered. Also what it is that they need to do to promote safety and all of those new things that they need to learn. So sternal precautions, spinal precautions, like make sure that those are included and those are your priorities over an area that they might be borderline functional. Unless everything's borderline, then you have an advantage. But some patients come in and they have so much going on, you have to prioritize. And do you realize that OTPF is your friend at this point in time when you're creating goals? And realizing if you use OTPF language, that can really make a goal all-inclusive. Toileting is probably the best example, toileting/toilet hygiene, because you're working on functional mobility, because you're getting on and off the commode, so you're working on commode transfers, clothing management, so you have lower body dressing tasks that are included, maintaining your balance on the commode and while you're doing hygiene tasks. All of that stuff is included, and so you can work on balance, coordination, dressing tasks, functional mobility. Like, so much can be included in that one goal. And so those are always, toileting is always a good, safe goal to include, on top of the fact that the bathroom is the most dangerous place in the home. So when you're creating goals, just be really wise and smart about what you choose to include and what you don't choose. And also, just make sure that when you go, your goals are like the hallmark of your plan of care. It's what's going to be followed and what's going to be the focus of the treatment sessions to come. That the goals that you make fit the deficits. And so if something was marked within functional limits, it shouldn't ever be included in your goals. My guess is you should really think about, oh, this is what I want them to be doing in this condition or parameter, but that's not the actual problem. And so just make sure that the actual problem is included in the goal, instead of the specific, I don't want to call it parameters because it's going to mix with my other language, but I hope that you can kind of garner what I'm trying to say there. Just be consistent and make sure you're choosing the right verbiage to fit with the deficits that the patient actually has. So that goes back to, don't pick supported sitting if balance isn't an issue. If it's energy conservation that you want to focus on because of an activity tolerance deficit, it's energy conservation techniques, or you're making a goal that's working on improving activity tolerance. So there's many ways that you can do it. Just make sure that what you're choosing is accurate and it is actually capturing the deficits that you're trying to target and to improve. And the more broad your goals is, the better, the more overarching and all-encompassing, like toileting / toilet hygiene is, the better off it is for your practitioners that follow you, especially CODAs, that depending on the facility may not just be able to upgrade, downgrade, or change your goals to fit what actually might need to occur for a patient. So I really hope that this gives you an overview of the evaluation process and everything that you can do to maintain the integrity of your documentation. My best words of advice is to be consistent, to be congruent, to really understand semantics, work really hard on developing your documentation skills to paint a clinical picture. And all of that is really overwhelming at first, and you'll go through periods where it takes you a really long time to do documentation because you're trying to hit all of these components and think about all of these things, and you also might be really lengthy and wordy. I think that it is worth your while to go through that journey and put in the time and effort, because eventually you will become concise and you will have great documentation, and it will have a lot of integrity and really help your clients. And other people may just want you to be zippity doo-dah from the beginning, and I think that this is the time to really learn good documentation skills and not develop any lazy habits, because once lazy habits are started, they're hard to break, and it does no benefit for you in case litigation occurs, and it does no good to your patients if they can't qualify for the services that they deserve and that they need. So hope this documentation series is beneficial to you. Have a great day. Bye.